I'll talk today about specifically about the pharmacological management of OA knees, because I think this is something which has been a very hot topic in the last 3 years or so, especially since the controversy over the withdrawal of Vioxx or rofecoxib came about. And so the question now is, with all these problems, with all these non-steroidal anti-inflammatory drugs, and even the so-called wonder drugs, the COX-2 inhibitors, where are we now in helping our patients relieve the pain that they suffer from osteoarthritis of the knees? I think the Analgesics can be broadly divided into these 5 main classes of drugs, of which paracetamol is probably the most common and the most easily available over-the-counter medication that most patients have access to. Then the other class of drugs are the non-steroidal anti-inflammatory drugs, or the NSAIDs, followed by these so-called non-selective NSAIDs, or meloxicam being one of the prototype examples. Then the new generation of drugs which came on in the last 8 years or so, and which unfortunately have been suffering quite a bit of bad press in the last 3 years or so, the COXIBs, or the selective cyclooxygenase 2 inhibitors. And last but not least, an opioid-like drug called tramadol, which we use fairly commonly in our clinical practice in the management of patients with pain from arthritis. So if we look at the most common drug which our patients really have very easy access to, which is paracetamol, otherwise known by its generic name as acetaminophen, it's really been recommended as the first line of treatment for relieving pain and improving physical functioning in patients with OA knees. But of course, I'm sure in clinical practice, you'll be very familiar with the patient who tells you, nah, paracetamol doesn't work at all. It doesn't relieve the pain as well as the non-steroidal anti-inflammatory drugs and the COX-2 inhibitors do. Well, I think one of the problems with paracetamol is because of its duration of action, and that's why it has to be taken 1 gram 3 times a day up to 4 times a day. And that's because if you do not take it in that kind of a dosage and with that kind of frequency, it basically isn't very effective at all. But if you look at the studies which have compared paracetamol with the non-steroidal anti-inflammatory drugs, objectively, the pain reduction and the global assessment of the patient's improvement in function is generally deemed to be less effective. In terms of its improvement in helping patients with OA knees improve their physical function, it's equally effective. And of course, with regard to the side effects, mainly the gastrointestinal side effects, it's really very much less. So paracetamol, in most of the recommendations by the international rheumatology groups, in particular the American and the European colleges of rheumatology, have recommended that oral paracetamol should be the first line of analgesic therapy for patients with knee OA, in view of its effectiveness, the safety profile, and its low cost. Now, having said that, a lot of people often wonder why is it that sometimes paracetamol really behaves like an NSAID, even in terms of its adverse reactions. That's because paracetamol, if you take it in its prescribed frequency of 1 gram 3 times a day or 4 times a day, can actually behave like a very weak non-steroidal anti-inflammatory drug. And if you go back into the pharmacology of the mechanism of actions of NSAIDs, you will recall that basically what non-steroidal anti-inflammatory drugs do is to block these 2 enzymes called the cyclooxygenase 1 and cyclooxygenase 2 enzymes. And these 2 pathways are very important. The COX-1 pathway is very important in the production of prostaglandins, which help to maintain the integrity of the gastric mucosa and also maintain hemostasis. Whereas the COX-2, or the so-called inducible pathway, is important for another function of the prostaglandins, which is the mediation of pain, inflammation, and fever. So what happens in NSAIDs, the way NSAIDs work is to actually block these 2 pathways, the COX-1 and the COX-2 pathway, whereas the selective COX-2 inhibitors like celecoxib or Celebrex and etoricoxib or Arcoxia only selectively blocks the COX-2 pathway, and that's why they have less GI side effects as one of the bystander effects. What about certain drugs like meloxicam, otherwise called Mobic, or the drug which has recently been discontinued by HSA, Nidol, otherwise called nimesulide? Nimesulide and meloxicam have a pathway which is somewhere in between, meaning to say that they block both COX-1 and COX-2, although they preferentially block COX-2 rather than COX-1. And these are clinically important pharmacological issues, which I'll explain a little bit more about later on. So in terms of the non-selective NSAIDs, which is the conventional NSAIDs, it's pretty effective for the acute relief of pain and the improvement in function. And generally, the recommendation in the last 2 years or so is that these drugs should be used for as short a period as possible for several reasons. Number one being its toxicities associated with the GI tract in terms of gastric perforations, ulcers, and bleeds. Number two, in view of its potential risk for nephrotoxicity as well, especially in patients who have underlying renal insufficiency or in the elderly. And of course, number three also is the very big question mark as to what exactly is the cardiovascular risk associated with these non-selective NSAIDs, and are they really the same as the risk that have been attributed to the selective COX-2 inhibitors? Well, fortunately, topical NSAIDs still haven't developed a very bad name of their own, and they have still been found to be pretty effective for the short-term relief of pain in OA. And most times, most patients who use topical NSAIDs really don't have very much side effects, except to say that some people do actually develop a contact dermatitis to the NSAIDs, either to its excipients or to its parent drug, with prolonged topical use. So the GI side effects are very well established, and there's lots of scientific evidence for that. The GI side effects, the risk factors being the elderly, the age more than 60 years old, if there has been a previous history of GI events, in particular peptic ulcer disease, and concomitant corticosteroid use. Now, I have to mention a little bit about concomitant corticosteroid use because I think in the last many years or so, there has always been a little bit of a misconception that patients on moderate or high-dose prednisolone or oral steroids are at risk of developing GI bleeds. In truth, that is not so, and the risk of GI bleed with corticosteroids only increases when you add on non-steroidal anti-inflammatory drugs together with it. Prednisolone per se in moderate or high doses may sometimes cause a little bit of dyspepsia, but it does not increase the risk of gastric perforations, ulcers, or bleeds. Of course, in patients who have symptoms or who have risk factors where you still feel that the benefits of using an NSAID far outweigh the risks, then there is recommended gastroprotective agents which can be used, either the use of proton pump inhibitors or doubling the dose of your conventional H2 receptor antagonists, be it either famotidine, ranitidine, or even cimetidine. And so, in terms of selecting patients who should or should not receive non-steroidal anti-inflammatory drugs, really an informed discussion with the patient in terms of its effectiveness versus the risks of the adverse effects and the toxicities really has to be discussed in detail before you decide whether these patients should receive these drugs or not.